So I think we might get started. Good morning, everybody. Thank you very much for joining us for this Ireland East Hospital Group hosted virtual Grand Rounds webinar. And it's really co-hosted by all the hospital groups. And we have some of the hospital groups CAOs on this morning. Just a bit of background, this meeting started about a year ago with a combination of themed meetings and clinical case discussions from groups around the hospital. But it very quickly involved other hospital groups, patients who are transferred between hospitals in groups and outside of groups. So we've had some very interesting clinical cases that have crossed hospitals and cross groups. We've had some interesting discussion about simulation, and this morning's discussion about introduction to NDTP, telling us more about NDTP for those of us who don't know about it, and then a wider discussion involving a lot of senior people involved in medical training in Ireland will follow on. So we will start with the video. Professor Lynch has just arrived. If you want to introduce the video. Or...
Yeah, sure. Welcome, everybody. This is an animation video that we've done out of the Chief Academic Officer Group and Health Affairs UCD, and I think it's trying to capture how we think we should develop Irish medicine over the next 10, 15 years. So we welcome any comments on it after it, subsequently be in the discussion, or any other thoughts or ideas.
And you might just need to turn your volume up for the video. Thank you. Want to start, Leslie? Thanks.
Worldwide research and innovation are improving healthcare at an extraordinary pace. However, rapid access to medical knowledge, personalized precision medicine, advancements in technology, and an aging population are all significant challenges. Delivery of these specialized treatments and innovations through the traditional hospital model can be costly, and the health system can become overwhelmed. To help address these issues, 7 hospital groups were set up in Ireland. A hospital group links a number of hospitals, or university, and their associated community healthcare organisations, providing better integrated care. To ensure the continual development of sustainable, quality and safe healthcare and the success of the hospital groups, we propose to establish an academic health science system, an AHSS. An AHSS is a fully coordinated partnership between a university and a healthcare system designed to deliver quality care hand in hand with teaching, training, research and innovation. Most importantly, the change from the traditional hospital model to an integrated academic health science system will improve patient care in local communities. Ireland has some of the best doctors, nurses and allied healthcare professionals in the world, but we lose many to immigration because of limited career opportunities. Embedding teaching, training, research and innovation into clinical services will improve staff job satisfaction, resulting in better recruitment and retention of high-quality Irish and international staff. Furthermore, clinical academic directorates within the AHSS will pool resources in key specialty areas such as cancer, cardiology, mind and brain disorders, informatics, women's and child's health, and genomics. Improvements in research and innovation will result in new treatments and new technology, leading to world-class outcomes for our patients. Other benefits of the integrated AHSS include increased research grant funding and the creation of an environment to encourage commercial opportunities and entrepreneurship. This will result in added value to the state by contributing to the knowledge economy, by improving state finances, and by improving population health and well-being. The AHSS offers a real prospect of achieving greater levels of productivity and efficiency, sustainable improvements in patient care, better patient safety and outcomes, as well as world-class research and innovation in healthcare. To find out more, please visit the UCD Health Affairs website and the Ireland East Hospital Group website.
Yeah. Okay.
Tomas and Tim, sorry, you'll need to unmute.
Sorry, Tim, I thought we were.
Thanks. Okay, I blame Tomas for that. He keeps muting me all the time. Thanks, Shane. I welcome any comments on that subsequently, so we might have that in discussion later on about the animation video. But it gives me great pleasure to introduce Brian Kinirons. I've known him for many years and his family for many years. Brian's a consultant anesthesiology and intensive care in Galway and a clinical lecturer in NUIG Galway. Most importantly, he's the recent medical director of the National Doctors Training and Planning Organization, and hence this really, I suppose, session today is all about postgraduate education. So I'm very much welcome Brian. Look forward to you, Tom. Brian, over to you.
Okay, thank you very much, Tim, and I'm very pleased to be with you today and to share the platform, the virtual platform, with my colleague Caroline Herron, who is our lead NDTP NCHD. And this is an opportunity really not just to talk a bit about who we are and what we do, but really focus on what NDTP does for you and your career. It's also apt for me to just acknowledge our NDTP training leads, and I'm here today at the invitation of two of our leads. On the left, Shane Hannon, and on the right, Dr. Tomas Breslin from Ireland East. And the Training Lead Network is a network of consultants in 5 hospital groups who really function as the boots on the ground for NDTP and have a responsibility specifically around education and coordination of education within that particular group, focusing on generic elements of the curriculum that are relevant not just to the training community, but for those doctors who aren't on training schemes as well. So I'm showing you this picture because it talks a little bit about my providence. Prior to my role in NDTP, I was president of our college, and I'm sharing this photograph with you because it was used by the college on several occasions, because it was told to me repeatedly that this was represented the least worst photograph that they had in their collection. I'm also showing it to you because it reminds me that when I actually told many of my colleagues that I was taking up a role in NDTP, that the response to this was, what is NDTP? So there is a sort of a large knowledge gap in a wider community about who we are and what we do, and hopefully this is about addressing that gap. In terms of the history, the unit was formed in 2014. It was done so in order to meet the statutory responsibilities as enshrined within the Medical Practitioners Act 2007 and the Health Act of 2004 in terms of the HSE's legislative responsibilities in terms of education and training. Now, there have been many additional pieces added to NDTP since 2014, and that would include things like medical workforce planning, DIME, and the consultants division. But at its core, education and training is really its core responsibility. And I guess in terms of today, we're talking about how we invest in you and in your career. And that speaks to the strapline at the bottom of that particular report, which says that we are about investing in the career development of doctors. And I hope to show you how we do that over the next few minutes. So at the heart of NDTP is a complex matrix of stakeholders, and these are by all means not all, but some of our stakeholders you can see in front of you here. A lot of what we do in NDTP is about building relationships and communication with external groups. Some of them are obvious, some of them are perhaps less obvious, and again, no less important but not visible within this particular map our relationship through the medical intern unit with the medical schools, the Council of Deans, and the intern network executive. Likewise, not visible, but equally important in this particular diagram, is our relationship not only with the acute sites, but also with primary care. And indeed, one of our goals in NDTP is focusing on increasing training input or training income into the general practice training program. We also have a relationship, of course, with mental health services, which of course includes the CHO areas and of course the acute areas as well. So there is a sort of a wide sort of landscape of people that we communicate with on a regular basis. There are three pillars, which I'm going to talk about. The first pillar, as I've mentioned, is education and training. The second pillar is medical workforce planning, which is complex. And the third pillar is the consultants division. So I'm just going to focus on these three fundamental pillars. And of course, this isn't the extent of the whole of the activity within NDTP, but given the time constraints, these are the core elements of what we do. So in effect, the unit itself is the organ through which the HSE effectively commission and fund postgraduate training. And it does so through a mechanism of a service level agreement with the postgraduate training bodies. This is a collaborative process which involves meeting with the various colleges. And amongst other things, of course, part of that process of agreement is the agreement of training intake. And that, of course, has to align with medical manpower, workforce planning, and future demand. And not only do we have SLA agreements with the postgraduate training body, but again, through our intern year, we also have SLA agreements with the medical schools, the 6 medical schools in Ireland. This is Hugh O'Callaghan, and my focus now is really around the training element of what we do. Hugh O'Callaghan is a post-CSCST fellow, and I show his picture with his consent. As it happens, he is a fellow in my hospital, and he is our fellow in regional anesthesia, and he is a beneficiary of the flexible training scheme during his training program. And certainly he tells me that this flexibility allowed him to continue training, whereas if he didn't have access to this, he might have had to leave the training program entirely. So NDTP recognizes the need for less than full-time training, and it funds the current supernumerary flexible training scheme. And there are some 32 posts in the country, and these posts are currently oversubscribed. We're also promoting the concept of job share, and there are several doctors on training programs in several of the training programs currently who are job sharing, and we would see this as a potential growth for those who want to work less than full time. Every COVID cloud has a silver lining, and certainly one of the obvious silver linings from my professional perspective is the infrastructural investment in critical care. However, the post-CSE fellowships are another area of a silver lining, and these were largely introduced during COVID, and this allowed doctors who traditionally would have traveled overseas the ability to actually engage in subspecialty training within Ireland. The funding for these posts were originally on a temporary basis, but I'm pleased to say that we now have a sustainable funding for up to 40 post-CSCST fellows. And that's important. So it's important for two reasons. One, it does define the fact that we in Ireland can train from the very beginning to consultant entry. It also speaks to the requirement to retain our doctors within the country. And certainly attrition at the post-CSCST level is a real issue that we need to address. And this is one of the methods we would like to think that would actually address that problem. And certainly we will focus and track these fellows to ensure that the fellowship translates to a consultant appointment within the Irish healthcare system. This is Conal Dennehy. Many of you know him, but for those of you who don't, he is a director of ICAT. And for those of you unfamiliar with ICAT, ICAT is the Irish Clinical Academic Training Program. So this is a sort of a program which allows academic leaders, and it's really about identifying academic leaders of the future to do an integrated PhD as part of their specialty training. And this is a high value program which we support, and currently NDTP supports 4 ICAT fellows per year. In terms of other training supports we provide, NDTP has been providing scholarships, the Dr. Richard Stevens Scholarship, since the 1970s. There have been 57 doctors to date who have been beneficiaries of this scholarship. And this allows doctors in their final years of training to access clinical sites of excellence overseas in areas where there is perhaps less exposure within Ireland. And this has been widely valued within the community. There's always there's great competition for this particular scholarship. And again, this year we've appointed 4 scholars and also given 4 bursaries to submissions of merit. So it's, again, a good program. One of the other elements of our activity is financial support for the training community. And for those of you unfamiliar with the TSS, I would say to you that your trainees are very familiar with TSS. This is the training support scheme for NCHDs. And there are 3 schemes currently available, which I've enumerated there specifically for doctors in training. And not only that, but the 4th scheme represents, of course, a scheme which is specifically for CME for consultants, which is administered by NDTP. In terms of medical workforce planning, this is a complex area. The unit resides within NDTP. And the ambition and aim of this particular unit is to meet the projected work needs of Ireland of the future. And this is really about ensuring that supply meets future projected demand. And that demand, of course, depends on things such as the aging demographic, innovation, technological innovation, and of course, changes to healthcare delivery, such as launch care, have also an impact on medical workforce planning. The unit itself does 2 particular types of reports. It does high overarching reports, and you can see there's an annual report there, and also a high overarching report to 2028. It also does specialty specific reviews, and you can see in front of you here there are 2 reviews. One is from intensive care medicine, and the second is psychiatry. And they do this in collaboration, of course, with the postgraduate training body. And again, these are granular in terms of the detail, and ensure that we have an adequate supply for what we see as projected demand. Just giving you a sense as to what's happened in terms of that manpower piece over the last 10 years. And this is really data that we've picked up from our DIME system. There has been significant increases in all sectors in terms of medical professional sectors over the last 10 years. And you can see that we've increased both our trainee and intern numbers by about 50% in a 10-year period. And most of those posts in training have been due to the conversion of non-training to training posts. And this is something that NDTP have been very active on in terms of trying to promote that piece of work. You can also see that there has been a 52% increase in consultant numbers. However, the red line item here, of course, is the increase in non-training scheme doctors, and I'm going to address Ireland's reliance on that. And that's largely driven by the increase in consultant numbers and new consultant posts. So I'm going to show you this slide here. There's quite a bit of data on this slide, but this is really encapsulates every challenge that Ireland has, specifically around medical manpower. So it's worth speaking to. And this is really a co-comparator between Ireland and UK and the home countries within the UK and Australia. And what I'm highlighting in red here is that Ireland has more non-consultant doctors per 100,000 population than any co-comparator country. The paradox is evident in yellow, and you can see that in terms of trainees, we have 88 per 100,000, and that is one of the lowest number of trainees per 100,000 population, again, in comparison to our co-comparator countries. The reason we have so many doctors is evident in green, and you can see that the glaring sort of outlier here is Ireland. We have 61 per 100,000 non-training doctors, and that is, we are an outlier of the order of magnitude of maybe 100, if not 200% in relation to our co-comparator countries. In blue, I've highlighted the fact that we have less consultants, 69 per 100,000, than any of our co-comparative countries. And we know that Ireland is one of the lowest numbers of consultants in the OECD. And not unsurprisingly, but disappointingly, the ratio of non-consultant doctors to consultants is evident in black here. And this is 2:1, and this is data from 2021. So, and that's some many years after Hanley, which advocated the reverse ratio. So it's fairly clear in terms of challenges that we have in Ireland related to increasing training numbers, the need to increase our consultant numbers, and the need to reduce our reliance on non-training scheme doctors. The last 2 years have been challenging because of COVID, but just wanted to share with you the fact that there still has been increases in the intern and training committee, some 15% over the last 2 years. Now that's largely driven by the increase in the intern numbers, which were at the behest of the Minister of Health. The numbers went up to over 900 during the early COVID years. The intern numbers are now back to 854, which is going to be, I believe, a steady state for the short-term future. You can also see that we've increased consultant numbers by 11% over 2 years. But again, disappointingly, you can see in the middle that the non-training scheme doctor numbers have increased by 270 in that 2-year period. So our third pillar, final pillar here, is the consultants division, and that really encompasses the Consultants Advisory Appointment Committee. And that committee is tasked with advising the HSE on the appropriate qualifications for particular specialist posts. It also aligns consultant approval and growth with models of care which are dictated in part by the clinical programs, and also aligns growth with national strategies such as the cancer care strategy. So consultant growth is not done on a piecemeal basis, but there is a sort of a plan behind it. I'm going to share with you some information around training exits and CAC approvals over the last few years. And you can see from 2018 to 2021, the training outputs tend to be fairly similar. We're talking about anywhere between 230 to 260, up to 280 perhaps last year in terms of training outputs. And considering that the training pipeline is anywhere between, say, 4 years for general practice up to 6 to 8 years for other specialties, you can see that this is a fairly fixed output at the moment. In terms of CAC approvals, you can see, again, there's been a fairly steady state up until 2020, about 260 approvals per year. Last year, the approvals increased exponentially to 553. So this is an enormous increase, which is welcome on the basis of the fact that it is an infrastructural, it's an investment in the human resource, recognizing that we have some of the lowest numbers in the OECD. However, it will, of course, provide challenges, not the least of which, of course, if you can't have infrastructural support for these additional posts, then they can't deliver their service. And likewise, you can see that the training program can't flex up in that short space of time to meet that exponential increase. And my concern in relation to this is that this will actually inevitably result in increased consultant vacancies within our healthcare system. The consultant division also has the doctor's integrated management e-system. This is a system which is shared by several bodies, including the Medical Council. And this is effectively a database. And NDTP spends quite a bit of time ensuring compliance, that the data that we're actually extracting from this database is accurate. And compliance levels would normally run to something in the order of about 95%. And as I said, this is an ongoing work to ensure that the data is accurate. The NEOR, the National Employment Record, is about results from the McCrath report. And if you're unfamiliar with it, again, I'd say that your trainees are not, because this is the big piece that they use to record issues such as occupational health. And it's designed to reduce the administrative burden of doctors who, by virtue of their training programs, rotate around the country to the various sites. Developmental funding is another aspect that we support in terms of training. There's an annual call for developmental funding. And these are thematic calls, but they're not exclusive to just the themes, but themes that have been used in the past. include NCHD welfare, patient safety, inclusivity, equality, and diversity. And these are actually, we seek submissions from the postgraduate training bodies for various developmental funding projects. And we certainly awarded 15 of these projects last year. And again, the budget for this is something between 400 to up to 700 and 800,000. So it's a significant investment again in postgraduate education and training. We recognize the fact that doctors who aren't on training programs need to be supported, as indeed do the postgraduate training bodies. The CPD-SS scheme is a scheme to support this community. And this is a fund which is again administered through NDTP, which supports the acquisition of up to 20 CME credits per year from the CPD-SS community. And I'm showing you on the right-hand side, NDTP has also funded through the colleges various CPD-SS specific courses to meet their needs. And as you can see on the right-hand side, there's a series of courses that are available through RCPI for this community. We also launched last year, I'm very pleased to say, a new e-portfolio. This is again recognizing the fact that the CPD-SS community need access to recording their training experiences, and not only that, but that these training experiences will be validated by the supervisors. And this is a e-portfolio that is now available free of charge to doctors who are not on training schemes, and the uptake from this particular piece has been very good. Simulation is key and to all postgraduate education, and I guess one of the challenges around simulation is the fact that you know, as doctors, we're expected to work as a multidisciplinary teams, but we actually tend to train in isolation. So simulation is one of those crossroads where we actually do have interdisciplinary education. NDTP has invested over $1 million in simulation in the last 2 years. And that's really supporting and recognizing the importance of simulation in education, but also the value and role of simulation has with regard to COVID-19 in terms of education and training and preparation for the pandemic. The CAO group, that's the Chief Academic Officer group, commissioned a national strategy on simulation, which was written by Professor Dara Byrne on the right-hand side, and this again was funded by NDTP, and this is again a welcome addition. The SPARK program is an innovation program. It's a national program which we share with the Office of Nursing and Midwifery and also the Office of Health and Social Care Professionals, along with the National Quality Improvement Team. And this is really about recognizing innovation amongst healthcare workers and actually supporting the healthcare workers to develop their own innovative projects. And NDTP have 2 innovation fellows, Rachel Bright Sparks, they are, Rachel McNamara on the left, who is a public health doctor, and Ivan Hugh on the right, who is in pediatrics. So coming to the end, to mention the International Medical Graduate Initiative, this is an initiative that we work with the various, the Forum of Postgraduate Training Bodies. And again, for those unfamiliar, this allows doctors from Pakistan and Sudan to come into Ireland for 2 years as part of their training program. We have 174 doctors currently working in this program. And again, it's something that we would support from NDTP. Finally, this is just a year in numbers. This is last year. It gives you a sense as to what we have done, where we have gone, and some of the activities that we have participated in. And very finally, just to say, my belief is that NDTP is, and my role is an advocate for doctors and specifically around education and training. And I think that if we are doing our job, then we are ensuring that the right doctor is in the right place at the right time with the right competencies. So thank you for your attention.
Thank you very much, Brian. We'll keep questions to after the next presentation. So if you're welcome to type questions into the Q&A box. We'll address those afterwards, or you will be allowed to be unmuted also. So we'll move swiftly along to our next presentation from Dr. Caroline Herron. So Caroline, if you want to share your screen. So Caroline is an SPR in general surgery, subspecializing in breast surgery. and is currently on an out of program year holding the position of National Lead NCHD. And this is a fellowship post based in NDTP division of the HSE. So thank you, Caroline.
Thank you very much, and thank you for the invite to speak this morning. I'm going to focus on a component of NDTP's work around medical education and training, and that's the Lead NCHD program. So for people not familiar, I'm going to run through the program and what it entails, and then I'll give a little bit of detail about what my role as the National Lead NCHD Fellow involves. So the Lead NCHD program really came about because there was an understanding that we needed to put in place a process to engage NCHDs, and there also needed to be a formal, structured two-way communication pathway between NCHDs and their senior management. The program was piloted in 2014, so it's been around for a couple of years now, and in 2015 it was increased to all acute hospital sites with more than 50 NCHDs. The program increased then in 2016 to include mental health leads, and in 2017, primary care and public health leads were appointed. For this year, 2021 to 2022, we have expanded into some smaller sites with less than 50 NCHDs and some specialty specific sites on a trial basis. So as of today, we have 78 leads appointed for this year. Any NCHD who's finished their intern year is eligible to apply. The application process and the recruitment is managed by the medical manpower managers. And the typical process is that people apply in around May or June before commencing their job in July. And typically this would be with a CV and personal statement or cover letter. And the medical manpower managers then arrange an interview for prospective leads. Funding for the entire program is provided by HSE and NDTP. And to date, at least 400 NCHDs have taken part in the program. So what is the aim of the program? So the program really came about to address the historical deficit of NCHD representation at senior management level. There is an appreciation that NCHDs, both individually and as a group, are essential staff in our healthcare system, and that we can offer valuable insight into the management and leadership of our hospitals. It allows an opportunity to input into issues which affect NCHDs and to improve our employment experience, therefore leading to improved retention and recruitment. So what is the role? So the lead NCHD really provides that formal link at management level between the NCHDs and their senior managers in the hospital. It's really important to note that the lead NCHD role is not specialty specific outside of those in the community, and it is representative of both doctors on training schemes and non-training scheme doctors within the site. The lead NCHDs are supported by the NDTP trainer leads who are appointed at hospital group level. So to the next couple of slides, just really touch on what the duties and responsibilities of the leads are on site. So they organise regular meetings with the clinical director and medical manpower managers to discuss issues pertinent to NCHDs and to progress joint initiatives. The lead either attends or nominates another NCHD to attend key meetings and hospital committees and participate in discussions and decision-making around issues affecting NCHDs. Where appropriate, they should be invited to attend hospital inspections such as accreditation, training body, or medical council inspections. The lead should have an NCHD committee of which they become the chair, and that allows them to meet regularly with NCHDs on site. They have an obligation to interact and engage with me as the National Lead NCHD and contribute to the wider Lead NCHD initiative. Together with their committee, they develop a work programme at the start of their tenure, and an important component of this is devising a QI project or improvement initiative, which they'll work on over the year with the overall aim of improving the working or learning environment for doctors on site. They should aim to ensure that NCHDs feel engaged and empowered to improve their working conditions, ensure they're knowledgeable of their contractual entitlements, and the supports available to them. We recognize the transient nature of the role. People rotate at least on a yearly basis, if not more frequently. So we ask for continuity to be promoted in terms of facilitating a smooth transition and handover to the next incoming lead to prevent duplication of work. So that's quite a lot of roles and responsibilities for the lead. So this slide outlines really what the benefits for doctors undertaking that role are. So first and foremost, the development of communication skills, examples of good project management and leadership experience, which obviously becomes so much more important the more senior you become in terms of your career development. They obviously have potential to bring about change, not only for the current cohorts of NCHDs on site, but for the groups coming after them. There are lots of networking opportunities for the leads to work with the other leads, but also the trainer leads and myself as national lead. Leads are awarded a €2,500 educational bursary to support training in management and leadership. And this is above and beyond the usual financial supports available to NCHDs. They have an opportunity to partake in the Lead NCHD Awards. They have 4 hours per week protected time to undertake the lead role on site. And they also get to attend workshops and webinars, which are arranged by myself. So I really would encourage any NCHDs who haven't held the role to consider it for July, or at the very least to consider joining your committee and think about the benefits that you could bring for yourself and for the site if you took on the role. Finally, then, the benefits for the hospital in engaging with this program. Well, Lead NCHD helps to integrate NCHDs within the clinical site and obviously facilitates enhanced communication between NCHDs and management. NCHDs are provided with an opportunity to participate in discussions and decision-making, not only around matters that affect NCHDs, but importantly for the site and for senior management. They are invited to give opinions on the day-to-day running of services, which they're all often in a great position to do, and to think about solutions and improvements to enhance patient safety and care. So that's really a whistle-stop tour of the LEAD program, how it came about, and the benefits for everyone involved in the program. I'm going to show you a few slides now on my role as the national lead. So the first national lead was appointed in 2016, and the role is a fellowship position working within NDTP. The national lead must have at least 4 years postgraduate experience. Experience as a lead is desirable, but not mandatory, but they must have shown participation in undergraduate or postgraduate training and evidence of previously contributing to change programs. The national lead also undertakes a qualification in management or leadership while in post, for which NDTP provide the bursary. There's also an opportunity to undertake a research study, and depending on your training body, the year may be approved for training. Obviously, the main skills needed are around leadership, project management, organization, communication, and teamwork. So the main, I suppose, pillars of my job, as I would see it, first and foremost, is to oversee and operate, embed and develop the LEAD NCHD program. So I support the medical manpower managers in recruitment. I provide induction and resources to the leads, support and guidance throughout the year. I manage and administrate the bursary by approving the courses that they wish to use. And I also arrange the LEAD NCHD Awards. So all of those quality improvement projects that leads undertake throughout the year are put forward for entry into our LEAD NCHD Awards, and we have a ceremony and award prizes. Obviously, I need to be available to communicate with the leads. For the most part, this has been via phone calls and emails for this year, but we're hoping with the easing of restrictions that we can move to some site visits. And another important part of my work around the LEAD program is to provide webinars and workshops for the leads. And these are really held within a few kind of areas like quality improvement, wellness, professional or personal development. So far this year, we've held sessions on change management, Schwartz rounds. We are due to do interview skills and negotiation skills in this 6 months. I provide a link to the medical manpower managers, training leads and other stakeholders, and obviously outside work to collaborate to embed and develop the LEAD initiative, all the whilst aligning LEAD NCHD initiatives to the wider HSE agenda. The second pillar of my work, as I would see it, aside from running the LEAD NCHD program, is to represent NCHDs nationally and link to senior management within the HSE. And I do this really by being in committees, working groups, and consultation forums. I act as a national contact point for those seeking NCHD engagement and collaboration, and I obtain and articulate the views of NCHDs at various forums, usually using my LEAD network, who in turn reach out to their committees and NCHDs on site. Some other things that I do, I provide support for NDTP initiatives. So things like the e-portfolio, I give demonstrations of that to interested doctors. We've recently developed a mandatory training matrix, which focuses on reminding NCHDs about the mandatory training requirements and giving them a simple link to follow to do that. We're also hoping to bring in a national employment record app in the early part of this year. So I really provide the NCHD voice for projects devised by senior management or the director within NDTP. There's also scope to provide momentum and support for projects that align with my own goals. So for example, increasing awareness around flexible training options, and we're hoping to do some work on return to training supports over the next couple of months. And really, the role of the national lead is also to encourage and support leadership amongst all NCHDs. Finally, in addition to supporting the leads, I do support all NCHDs, and I do this via the publication of a newsletter, which I have developed to come out quarterly. And this kind of focuses on a lot of the supports in terms of financial supports, employee assistance program, reminding NCHDs about flexible training and scholarship opportunities, but also focuses on good news stories and highlights some of the QI projects that the leads are doing around the country. So I'd encourage everyone to get involved, and you can contact me here if you have any queries or questions, or if I can help with anything, nl.nchd@hse.ie. Thank you very much.
Thanks, Caroline. That's great. And thanks, Brian. Tomas, myself and Shane might go from here at this stage with that. We have a very big panel and with representation from the College of Physicians, the College of Surgeons, the Postgraduate Forum, the Medical Council, the Chief Academic Officers, NCHDs, etc. So what we might do actually might be easiest is if we're going to go down the list in front of me here, if the panelists wouldn't mind briefly introducing themselves, and then we're going to go to questions and answers about the two talks and postgraduate education in general. I might just get my little dig in right to the start. I've always had an observation. I thought if we had good career pathways and structure and terms and conditions for positions, that we would attract more and more good consultants and retain good junior doctors in Ireland. And we haven't quite got that right yet, although I think we are moving in the right direction. And the other comment I make, I've always had a problem, we don't do mentorship well in this country, in that giving good advice and mentoring people through the career. And I'd be interested in subsequently maybe Karen's comment on that, because I think it's something we're poor at and we should develop further. And furthermore, our interdisciplinary work and teamwork is poor. Simulation, as Brian said, is very important, but team academy might be an option. We should consider these issues. So that's my brief dig. I'm going to go down the list in front of me here at the moment. I'm going to ask Helen Welton. Maybe you might briefly introduce yourself, Helen.
Morning, Tim. Morning, everybody. Helen Welton. I'm the Chief Academic Officer and the head of the College of the Chief Academic Officer for the South-Southwest Hospital Group and the head of the College of Medicine and Health in University College Cork.
Thanks, Helen. Ken Mealy.
Ken Mealy is my name. I come from a surgical background and I chair the forum of postgraduate medical training bodies.
Thank you. Joe Keane.
Joe Keane, Trinity St. James. Thank you.
Colin Kelly.
I come from a surgical background. I'm currently CEO of RCSI. Thanks.
John McManus.
Medical consultant, training lead, UL Hospital Group, and also regional program director for the Midwest BSD scheme.
Thank you. Owen Smith.
CAO for CHI. I'm a hematologist by training.
Suzanne Crowe.
Good morning. My name's Suzanne Crowe and I'm president of the Medical Council, and I'm also a paediatric intensivist with CHI at Crumlin. And our role here on the council is regular education and training.
Thanks, Suzanne. Greg Swanwick.
I'm a psychiatrist. I'm one of the NDTP training leads for the Dublin Midlands Hospital Group, and I'm previous Dean of Education for the College of Psychiatrists.
Gozia Faya.
Good morning, everyone. My name is Gozia Faya. I'm the clinical lead for the medical intern unit within NDTP.
Hilary Humphreys.
Good morning, everybody. I'm the CAO for the RCSI Hospital Group and a microbiologist by training.
Mary Horgan.
President of the Royal College of Physicians, former Dean of the Medical School in UCC, and consultant in infectious diseases, CUH.
Orla Crosby.
Morning, gastroenterologist at CUH and one of the training leads for the South-Southwest group.
Paul Reedy.
Morning, I'm an infectious disease SPR and lead medical NCHD at the Mater.
Thanks. I think that's everybody. It kept flipping around. I've forgotten somebody in the panel. Please shout. My apologies. It moved around as I was calling names out. So that's kind of our panelists. We might open discussion. Maybe Tomas wants to take a question to start with, and then anybody, the panelists, want to comment or interject, and also the two speakers, please do.
I mean, there's a theme in the questions. Jared Crotty, one only has to look at the news headlines to see the huge gap between aspirations and reality, especially as it relates to doctors in smaller hospitals, most of whom are not in training. Isn't there a risk that NDTP activities will increase the gap unless all training opportunities and academic initiatives are made equally available to non-training NCHDs as to trainees? And just there's a sort of added connected point from Larry Crowley. Nobody seems to have responsibility for recruitment and training of non-training scheme doctors, either at group or national levels. The result is that each hospital has their own recruitment for these posts. And I think Brian has acknowledged that we have a higher proportion of non-training scheme doctors than any comparable health system. And I don't know if anybody wants to, if Brian wants to take that up, or we have no hands raised.
If I could just perhaps before just make a point, there's two pieces around that recruitment in terms of there is in terms of one of the challenges in terms of our numbers of non-training scheme doctors is obviously recruitment occurs driven by service need, and that happens on a local level. Training on the other hand is really a national piece and the central control around training, and so that's really where the challenge is. There is no centralization of recruitment of non-training scheme doctors, and that's why there is growth. In terms of the smaller hospitals, just to say that there is a challenge with the smaller hospitals, and we recognize the fact that many of these hospitals are challenged in terms of recruitment at consultant level as well as at a non-consultant level. And NDTP are just embarking on a project specifically looking at the recruitment and retention challenges in the Model 3 networks in all specialties. And this will be kind of a solution-based piece where we were looking at how we can incentivize recruitment within that network. And my belief is if we don't, there will be huge challenges in service delivery in the short-term future. Thank you. Thomas, you're on mute.
We're back again. Thank you, guys. Mary Horgan, your hands up.
Yeah, hi, and thanks for the two great talks. I think it's really important that we move on from the one-size-fits-all way of training so that we can diversify the skill set that our trainees have into, you know, everything that Tim's video had in the front. The other thing that we have done in the College of Physicians is have fellowships in managing consulting. We think it's really, really important that our trainees have the skill set to really be able to shape our healthcare. I think there needs to be more doctors in leadership roles within our health service. So we now have 5 trainees who are training this area. It's incorporated into our into our training program. So beyond innovation, research, education, the importance of developing skill sets in that areas. And I think it's a reflection of what we've seen in the past 2 years, how much of the consultancy firms have been involved in shaping a lot of the things that have happened. And the second thing, and really picking up on Caroline's point, is really for the trainees to become involved in committees at levels within the college, within their faculties, so that they gain that experience and really shape what we need to do as training college. So I think really emphasizing moving on from that one size fits all you know, allowing people to develop their skill set so that they can do different things, not 100% clinical all the time, but formally doing education, research, true healthcare leadership is really important. Thanks, Tim.
Thanks, Mary. I very much echo that. I just make an observation. It's quite interesting. In the States, the academic health science centres are all run by doctors, which is interesting. Whereas in Ireland, the doctors are never considered in the position for CEOs of hospitals. The exceptions being, I think, the masters in the obstetric hospitals, and particularly as Helen Welton pointed out, John Higgins has control of the budget in Cork. And this is an interesting model and an appropriate one. And in many ways, the animation video probably doesn't touch, but would imply that it's implicit. Docs need to be running these major units because actually we can have the correct direction of how the hospital should run in the groups. Carl Kelly, your hands up.
Thanks very much, Tim, and thank you to Brian and Caroline on their presentations. Firstly, can I just congratulate Brian on the work that he and his colleagues in NDTP are doing. I think it's really important and a great example of clinical leadership. It's important that we have a clinician in that role, and the work that's going on is really, really impressive. From our point of view at RCSI, our focus is on education, research, and service. On the educational side, a big new emphasis on well-being, exemplified by a Centre for Positive Psychology and Health, and also education and health systems science, which has been lacking, and I think Mary has alluded to. Our research is as well known, but what's really interesting for us is our focus on health policy. And there's two kind of mismatches here. Number one, our over-reliance on non-training doctors. We need to be imaginative of how we deal with that. And one area that hasn't been talked about is task shifting, what we call one step up, which has been highlighted during the response to the pandemic. We should be looking to expand the scope of practice of other professional groups, such as physiotherapists, nurses, pharmacists, and introducing new professional groups. Many of you have worked in the United States where physician associates play a key role. We're now graduating our 7th cohort of physician associates in a pilot scheme, and we see expansion of that key professional group is offering an opportunity to ensure a better environment for trainees. The other one that I would appeal to as a training body, and I think would just be tremendously helpful for us to have some sense of, and I know it's not an easy one, but it's around workforce planning. If we had some idea of what the concrete aspirations of the government and HSE is for consultant numbers, we can start to proactively plan in that direction. So again, really enjoyable conference, very informative, and my congratulations to all on what's been done. Final comment on the animation, Tim. I think it's the academic health centre model is very attractive. But I think the reason it's not gained traction in Ireland is there is a risk that we're abandoning the level 3 hospitals and probably not involving community care enough, but not a reason not to go for it. But I think with the breakup and change in the structure of the hospital groups, there is an opportunity to recraft the vision, which hopefully this is a start of.
Thanks, Golly. I just commented that it's called a system for that purpose. In the States, we think of academic health science centres, but the system implicitly implies the community needs to be involved. So otherwise it won't work. So it's a model actually how you can actually implement Sláinte care. And the real purpose of that is actually, I think we need policy and legislation to support that. So that the hospital groups that actually have been successful and were embryonic in developing could be retained in fashion, because then the level 3, level 4, level 2 hospitals would work together and then all boats lift. So I completely echo your comments, but that's specifically why it's called system rather than centre. Suzanne, come to yourself.
Yeah, I'd just like to echo the comments made by the previous speakers and thank the NDTP for their role in pushing this forward, but particularly what Cathal says about workforce planning. The data that we collect in the council shows that we have a major issue with international graduates and international medical students. We need workforce planning almost specifically targeted to the now 1 in 4 doctors in our country that we rely on that actually began their medical education and training outside Ireland. We have an over-reliance on these doctors, and yet we are actually failing them in terms of training opportunities, which means that when we collect data on the council from doctors who leave the register, we see that many international trainees and graduates leave within a 5-year period. So they contribute to our healthcare system. We don't provide them with the opportunities, and then they take their knowledge and experience with them and leave our country. So I think workforce planning that specifically integrates medical students and doctors who've started their training outside Ireland, that we're really going to have to target that. And I'd really welcome any other further comments on that subject.
Thanks, Suzanne. I often think sometimes that we actually have an opportunity to do business there, because I think we all know the clinical training in Ireland with how to assess the patient is good. So, for example, the cost expenditure on the healthcare in the States is so high that frequently often the patient comes in as a shotgun approach to investigation, rather than the focused history examination and then the focused investigation and therapeutic approach. There could be a lot of cost savings in that if we did some re-education potentially of individuals, even from the States or elsewhere, in clinical medicine. But that's actually a product that we could sell. So I think you're right. I think how do we look at international training, and perhaps we do have a role in that area, but we are small, but we actually have a certain skill force that could pass on that clinical skills that we probably underestimate. Ken Mealy, your hand's up.
Thanks, Tim. I think it's important to point out that the forum speaks with the collective voice of all the training bodies, and we don't underestimate the huge challenges faced by all the hospitals in terms of training and aligning that with workforce issues. I think that the forum works closely with other stakeholders, and for instance, the Medical Council currently has draft guidelines for standards, and I think that for training in hospitals, and that will challenge many of the sites that we're talking about, particularly the smaller hospitals. So the forum currently has a strategic framework looking at training over the next 10 years, and one of those pillars within this framework is to help professionalize training at each site. And I think this is one of the mechanisms in which we can support smaller hospitals, but it's also one of the mechanisms in which we can support the so-called non-training doctors. And the forum looks upon its role as sharing information between the different training bodies so that best practice can be taken on by each of the training bodies. So, for instance, having a core curriculum for health and well-being, a lot of the skills that Caroline discussed earlier on, the leadership and training skills that all doctors need. So there are mechanisms in which we can address some of these issues, notwithstanding the huge challenges. Thanks.
Owen Smith.
Yeah, just briefly, thanks, Brian and Caroline. That was fantastic. Back to workforce planning. It's one thing creating new consultant posts in the country, but I think you alluded to this earlier on, Brian. It's creating that infrastructure that will really attract these individuals back. So it's great to see the 558 last year going through CAC, but you know, we've had a number of individuals over the years who come and look at CHI and whatever, and they say, well, so where's the infrastructural support? And they go back to Australia or North America, wherever. These are Irish graduates. So we really need to address that as well when we create new consultant posts. It comes with a package as opposed to just a job. Thanks very much, Jim.
Thanks, Owen. We might come to more questions. Actually, sorry, Yvonne Amara. Yvonne, your hand is up.
Can you unmute yourself, Yvonne?
Tim, I think my hand is up in error. I'm listening very carefully, but I don't have anything to add at this point.
Okay.
Okay, we have
yeah, thanks.
We have a question from Keith Sennett. Do we know the cost of implications of converting NCHDs to consultants to address the imbalance when compared to other comparator countries?
Sorry, I didn't get that. Could you say that to me again, Thomas?
So do we know the cost implications of converting NCHDs to consultants to address the imbalance, and Then Keith has also come in with, should the system become less reliant on NCHDs? Do that, not sure what, yes, it's a similar point, I think.
So, I mean, there are two elements to that
The
question.
cost of replacing.
Yeah, I don't, I mean, I do have oversight in terms of the cost of converting a non-training to a training post is relatively small. If you look at the numbers of posts that are actually have actually been approved by CAC last year, 553, the vast majority of those posts are new. So there is actually, there's no cost saving there. These actually are de novo posts and the funding has to be found de novo. So I think there's a relatively small cost for conversion to training. The challenge we have is as fast as we can do that, the number of non-training is growing even faster. So we're behind the curve at the all the time. And I'm very conscious this in terms of, as a country, we have probably more medical graduates than any other country in the OECD. And we have a retention issue. And I think the retention issue is around CSCST. Our sort of data would suggest most of our interns travel overseas, but most of them come back and start training programs. But we're losing up to 30% of our CSCST community, and that speaks to pieces like infrastructure and speaks to supporting the service delivery that these consultants need to do. So I think that's something that we need to work on nationally.
John has his hand up. John, do you want to unmute yourself? Thanks.
I'd just like to thank everyone for the fantastic talks today. I just have a few comments to make. And I suppose the first comment would be, as a group, do we think we're training the specialists that the country actually needs and where the country needs them to be based? Or are we training specialists that the training bodies want to train? And what the medical profession wants to train. And I think this comes into the concept of generalists and specialists. It needs to be further considered. And as part of that, I think we need to consider regionalized training programs. And I look at radiology as a great example of that. So in the Midwest, there's a local radiology training program. It's very successful and it's very popular with local trainees. And I wonder, could other, for example, I'm a medical physician, could we have more regionalized training programs? And I don't know why we can't. On top of that, I think we need to look at more options for flexible training. And I know interns don't have the option of flexible training. I suppose my final query or comment is, and apologies for in the background, I'm still struggling to understand why we cannot increase the number of SPR training programs in the country. And I'd like to know what the cost is for increasing the number of, for example, SPRs in any training program to convert a non-training registrar post to an SPR training program. The feedback I get locally is that doctors from abroad would like to do SPR training programs in Ireland, and they don't have any expectation per se that there would be a consultant post at the end of the day for them, because they realize this is a small country. But they know that if they get SPR training here, they're very mobile internationally. And I think we need to look at that. Why can't we become why can we not increase the number of training spots in Ireland? Thank you.
Okay, John, thanks. Maybe the panel want to take that one on?
Yeah, perhaps I could comment on that. I think one needs to bear in mind, particularly for the craft industries in medicine, you need a certain degree of clinical volume to be able to train. And this is one of the issues with the smaller hospitals. It's very hard to train surgeons in smaller hospitals where it's small volumes of cases. So I think we are limited in certain specialties in how we train and the number we put on training bodies, training schemes.
Yeah, maybe I can agree with that. I think the groups, though, do an interesting approach to that. Potentially, if the groups do develop further, I don't think the fat lady is sang in the group yet. So I think there's still an option. That's the purpose of the IEHSS, that the groups could do that. You could imagine, with discussion with the College of Physicians, College of Surgeons, is there a rotation or a training scheme within a group, provided it's big enough? But that then the group implies that the level 3 hospitals, level 4 hospitals, and the community are all part of that. So they work together as a team, which I think would be appropriate. Helen, you have your hand up.
Thanks, Tim. It was actually going back to attracting people back to the country. And we were looking recently at a photograph of the beach in Perth on Christmas Day with all the our junior doctors that are working out in Australia. And There indeed seems to be a huge number of them abroad and many of them don't come back. So I just wanted to reiterate really the importance. If we are to have an academic health sciences system, we have to have attractive offerings to bring those ambitious people back who want to do research and who want to develop an excellent health system. So just would really wanted to reiterate that we just need that protected time. That's the photograph.
That's the photograph of the junior doctors on the beach in Perth on Christmas Day. If you squint really carefully on the right-hand side, there's Helen Melton's daughter, actually. I think.
That's right. I have a best
So there must be about 500 junior doctors on the beach in Perth, all Irish. So the picture speaks volumes.
I just think it's
that's
really
because they're locked in Western Australia and they can't go anywhere else outside Western Australia.
That's true, Mary. That's true. Maybe we need to close our borders to keep what we have here. So just the new contracts need to have protected time for research to make the offering more attractive.
There's just a few, thank you, Helen. There's just a few more comments that we didn't get to from Cynthia Herron. IT virtual learning has come to the fore during COVID with very positive feedback around delivery of training, attendance at mandatory courses and involvement in meetings. However, IT infrastructure varies widely nationally. Can we improve the facilities to ensure all our trainees have equal access and facilities? And that's one point from Cynthia. Another point from Cynthia: can all NCHDs, so non-scheme doctors, be invited? And essentially, there was an open invitation to this through the group. So it may be that we need to have more of these sessions.
Yeah, I mean, this forum meeting is IEHG, but we're very open to this being used in a national setting for important topics, because I think today's discussion is interesting. I mean, we're going to run over here, but I think appropriately so is so important. So this isn't restricted to trainees, otherwise it's open to others. It's also open to interdisciplinary work. So I know we've some nurses on the session too as well. That's appropriate, but also we should have allied healthcare professionals if interested. So the forum can be used for other purposes.
There's a comment that we want to keep our trainees here and allow our training to be done here. However, there is still a view widely held that if you haven't been away and trained abroad, it says you are good enough, maybe not good enough for a consultant role.
Yeah, it's something we discussed a bit. Personally, I've always felt that actually having some experience abroad is helpful, not least of which is life experience, looking after yourself and managing things and then coming back. But in addition, you bring new skills. So I think we discussed this with Mary Horgan as well before, I mean, with Cathal, but actually having formal rotations abroad that could be structured and built into these rotations with a link back internationally could be done. We don't tap into the experience among the consultant body with international training and links. We haven't done it properly. And I've been trying to develop a link in Columbia University in Europe where I did my training. So I've appointed an adjunct professor of neuroscience to UCD, and I was appointed back. So I have an adjunct role in Columbia University. And we do every 2-month meeting virtually during the pandemic. And we're trying to see, can we build upon that there could be rotations, either junior doctor level or student level, or indeed at more senior level. It's difficult because of lots of issues as regards visas, etc., but it's doable. And I think having those built personally, formally into some of our rotations would make those very attractive. So I think there's no reason why we couldn't explore them.
Orla's got her hand up.
Orla Crosby.
Thank you. Just a quick comment. With regard to recruitment and retention, going back to everyone's point, I don't think we have a culture where we encourage people to go back. I think the consultant appointment mechanism is very unwieldy, and it's almost like Ireland's fittest family. You know, if you can survive to get to the end of it, and then the whole contract process takes so long, I don't think it encourages people. And another thing that I think we could be better with is encouraging partners in the healthcare profession, or perhaps in other professions. We don't make any allowances or don't seem to be flexible to attracting couples back to Ireland. And I think that would have a huge influence for some couples. One of the couple gets lost, so the other one won't come back at either the training or the recruitment consultant stage.
Good point. I think that's a very good point, Orla. Yeah. Brian, your hand's up.
Yeah, thank you very much. Just to address a few of the issues. I mean, I think Orla is correct. I think the concern, there is a disparity between the voluntary and the non-voluntary sector in relation to recruitment consultant, and the non-voluntary sector is at a disadvantage, and the current process is slow and I would say not fit for purpose. In terms of the away versus stay, I think the number of post-CSCST fellowships are only 40, so the numbers are limited. It doesn't mean that you can't go away, but it does give choice to those who choose to stay for whatever reason. And the challenge at the site is to ensure that the fellowship is of an equal quality that will make the actual fellow competitive at subsequent interview. And if they're not competitive, then obviously there's no value in that. And virtual learning definitely is here to stay. And I think there has been a recognition of that. NDTP certainly gave one-off funding to the training bodies to recognize their pivot to the virtual environment. And certainly it's going to be a part of our future, if not of our past. So thank you very much.
Thanks, Brian. This meeting this morning is a good example of that. This is otherwise it'd be hard to reach out to so many groups in this. I think you're absolutely right. The virtual way is the way to go. You've comment from Claire Fallon, Tomas?
Yeah, and Claire, thank you for a national meeting like this to a wider audience would be very useful. The level 3 recruitment process issue is a huge one, as are the different consultant work practices. If senior trainees do not work in level 3, for example, radiology, ED, and the others, they will never come and always consider level 3 as second grade science. So that's from Claire. And
that's where I think the groups could come in, actually, Claire. Again, if you have a rotation and training that you're doing a rotation among a group, then you're going to go level 3, level 4, and elsewhere with it. So it then becomes more interesting. So that's the importance of the groups and I think the HSS. Orly, you still have your hand up. Did you have a further question? Or
I think we're going to have to come to a conclusion. But since the gap in human resource management between Ireland and Australia is very large, junior staff get very well looked after in Australia, according to those. That certainly was my experience when I went there. We put up in accommodation for a few weeks until you got settled and things like that. But these are difficult issues to resolve. Yeah.
So maybe the College of Physicians, College of Surgeons need to develop a big beach for us with better weather. Actually, might attract them all back for Christmas. All right.
So thank you.
We run over, but I think it's very worthwhile. I mean, both everybody, Shane, myself, to must thank the speakers very much for excellent talks and introduction. I think the conversation was great. We touched on a lot of issues. There's a whole bunch of things to pick up on that. So, I mean, I think it highlights maybe a need to do this again in some fashion. It might be a conversation with our CPI and our CSI. Is this something we could look at again? Because the comments are obviously, I think we had a good nearly 90 people in attendance, but there's many others out there that'd be useful. And I think this was very helpful. Lots of good ideas. Much appreciated. We might try and follow up on a few of those. And I thank everybody for interaction and all the input. Thank you all.
Thank you.
Thank you.
Thank you. Good morning.
Cheers.